Morning, everyone, and welcome to our regional geriatric virtual rounds. For questions regarding the presentation, so when we come up to the Q&A portion of our presentation, please use the Q&A button or the chat button located at the top right-hand side of the event window. Write your questions in there, and then we'll make sure your questions get asked during the question and answer period. So at today's regional virtual rounds, geriatric virtual rounds, Dr. Alan Huang, who is the chief of the Division of Geriatrics at the Ottawa Hospital, will be presenting on better preparing older people living with frailty going for non-cardiac surgery. Dr. Huang is the head of the Division of Geriatric Medicine at the University of Ottawa and the Ottawa Hospital. He's a graduate of McGill University. In addition to geriatrics clinical service delivery and teaching activities, he has a long-standing interest in clinical informatics, and is the co-inventor of the medical office of the 21st century electronic prescribing solution. Other highlights include co-author of the chapter Medication Use and Falls in People with Cognitive Impairment, Assessment and Management Strategy in the book Falls and Cognition in Older Persons. He's the co-editor of the book of Medication-Related Falls in Older People, Causative Factors and Management Strategies. Completed the Right Prescription Project, the largest trial studying the effectiveness of computer-assisted medication reconciliation on administration and at discharge from hospital. Completed the Ottawa data collection for the MedSafer Canadian multi-center study and optimal prescribing recommendations for hospitalized older adults. Studies looking into the detection of frailty in older patients going for elective surgeries, and the co-author of the Geriatrics 5Ms communications framework: mind, mobility, medications, matters most, and multi-complexity. With that incredible busyness of his schedule, including clinical and research, he also finds time to cycle long cycle rides of 100+ kilometers, and is able to juggle all of that and still remain very collaborative and very willing to help out at any moment. So please join me in welcoming Dr. Alan Huang for his presentation.
Thank you, Kelly. I hope everyone can hear me all right. And if you see me on video, then you'll see that I have a very neutral background, Dow Lake in the fall. So let's see if I can. All right. Okay, let me see if I can advance the slide. It's not responding to my clicks. So I might as well, so I think, Stephanie, I'm going to allow you to control the slides, and that way I'll just say the next slide. So the next slide, please. I have no conflicts of interest to declare for this presentation. Next slide, please. Three things I hope the audience will learn today. I want to review the construct of frailty, what it is and what it is not. I want people to understand how the presence of frailty affects operative outcomes in older people, and to describe to you what the PREPARE trial is about. Next slide, please. So what is this thing called frailty? Next slide. Is it an American psychological thriller film? Next slide. Is it a journal cover story? And this was the Canadian Medical Association Journal in September 2018, highlighting the issue of frailty. Next slide, please. Or is it a physical condition? So when people look at this teacup, you'll say, oh, it is frail. Maybe yes, maybe no, but it's really fragile looking. But if you look at compressive strengths of materials themselves, Next click. Concrete has a compressive strength of 2,500 to 10,000 pounds per square inch. Next click. Mild steel, 22,000 pounds per square inch. But bone china porcelain has the highest compressive strength of 50,000 psi. So in fact, materials strength-wise, that china teacup is stronger than anything else that we have. But you'd also say, okay, well, I thought that was frail. Maybe I would have to say that is fragile looking, especially since it's broken now. And the reason why it was broken is probably a chip had happened onto the rim, and that weakened the structure. Next slide. There have been lots of words that have been attached to this term frailty, and some of these you see on screen in this particular word cloud. The next slide. So very importantly, this is what frailty is not. It is not a disease. It is not a diagnosis. It is not a medical condition. It is not a disability. And it is not the same as another term called sarcopenia. In fact, sarcopenia is a condition and a diagnosis. So frailty is none of those things. So how have we tried to attempt to define frailty? And you see certain words that have been used in the past attempts. Dependent people, they're debilitated, they need help from others. There's the principle of loss of function and stamina and vulnerability. Next slide, please. So here are 3 pictures of older individuals, and just by looking at them, can you tell if any of these people are frail? And if you look at the lower left-hand corner, the man with a cane, you'll say, aha, he's got a cane, he's walking, must be walking slowly. Yes, he's frail. Then if you look at the upper frame where the woman is obviously shopping in a market, she's got a cane, she may be walking slowly, and you would say, aha, frail. And then the lower right hand, of course, you've got this very determined looking Eastern European older woman who's facing up to the riot police. Well, you'll say, no, not at all frail. But our observations just based on seeing them may be flawed. So we can't really determine frailty just by looking at somebody. Next slide, please. So the better definition of frailty is someone who has decreased reserve and resistance to stressors resulting from cumulative decline across multiple physiologic systems, and they become vulnerable to adverse outcomes, especially when stressed. And Linda Fried proposed this definition back in 2003. Next slide, please. So when you have decreased reserves, and depicted in this cartoon, when you're young, you have lots of reserves, so stresses, you can get through those stresses quite easily. But as you get older and older, and physiologic systems have aged, you're left with less physiologic reserves. So a smaller stress can sort of push you over the edge and you can get into trouble. Next slide, please. So frailty is a state of being of a person. And it is, I like to consider it, it's like the state of happiness or being happy. You can be very happy one day and not so happy the next. So it changes, it's dynamic. You can't put a diagnosis on happy. It is a state of being, so it's a construct. So that, if you remember frailty is like happiness, then I think you've changed your assessment of that particular state, so that if you remember back to those pictures of older people, you don't know whether they're happy or not just by looking at them. Sometimes you can, and it's a little more difficult nowadays since we're all having to wear masks You can't always see the smile, but you can see the creases around people's eyes if they are smiling behind the mask. Next slide, please. So how does one detect frailty? There are many tools that exist, and I'm going to just highlight 3 and really only 2 to 1. There's one called the rules-based, and that's the frailty phenotype that was proposed by Linda Fried. There's an index variable base of frailty, and that comes from the Canadian Study of Health and Aging, and it includes 70 items, so that's not going to work very well if you're a busy clinician. And the last one is a clinical judgment assessment, and it's called the Clinical Frailty Scale, which was invented by Ken Rockwood in Halifax. Next slide. So for instance, this is the Fried phenotype. So there are 5 items: person who has weight loss, who's exhausted, who's slow, who's got low activity, and who's got weakness. Some of these things you can measure, and if you measure positive, then the more you have, the more frail you become. Next slide. The frailty index, like I said, there's 70 items. Many of them are associated with older people and declining function, but you're not going to count all these up. It was just a statistical result from the Canadian Study of Health and Aging. So very few people would use this. In large database studies, you might use this index, but in clinical assessment, we don't usually use it. Next slide. Here's the clinical frailty scale. Rather simple looking. So you have a little cartoon or silhouette, and you have a descriptive paragraph, and you have a number that's associated with different levels of frailty. So from very fit to terminally ill. But the simplicity of this assessment tool hides a lot of complex assessment behind it. You can use this tool by interview of a caregiver, but that person, the caregiver, needs to know the patient very, very well and their functioning. Or you have to go through a relatively focused, comprehensive assessment to know what all the patient's capabilities are. Next slide. Why does frailty matter? If you are a person living with frailty, you can become sick easier because of the lack of reserve. When you're frail and you get into trouble, you can become more frail after that. And the level of frailty is an independent predictor of bad things happening, regardless of how many comorbidities you have, how many medications you have, what you can and can't do in terms of your daily living activities, and whether or not you have severe disease states such as congestive heart failure or COPD. The predictive value is independent of all those. So if you can assess a level of frailty, you've got a very good prognostic tool. Specifically, if you score on the clinical frailty scale 7, 8, or 9, that's very poor outcome, regardless of whether you're going to offer the person just standard treatments such as intravenous fluids and antibiotics. Next slide. So just to show the data that was associated with Rockwood's clinical frailty scale, if you look at the 0.5 probability of an adverse or probability of survival, etc. So you see that the more frail you are, the less likely you're going to be alive at 6 years, and you're also going to be institutionalized, have a higher chance of being institutionalized the more frail you are. So highly predictive number. Next slide. What I'd want the audience to know about is this other tool. It's called the Frailty Assessment for Care Planning Tool, or FACT tool. It's really a composite of the clinical frailty scale in an easy to use grid format that can be used with interview of a caregiver and after assessment. Next slide. Here's the composite table, and I'm going to show you each of the domains so that you get a sense of what's really going on. But the fact table, what you do is you end up putting a dot where down each column where the domain has been assessed to be at the worst level. And then when you look at the table in its entirety, the level of frailty is the lowest one that is achieved across the entire grid. So in fact, if you score 5 on 3 of them and 7 on 1 of them, the worst score is 7. So the entire frailty scale score would be 7. Next slide. Here are items in the mobility domain. So you see that you go from thriving and doing very well to being bedbound and unable to participate. So the descriptors are fairly good, and the discriminators are also good. So you'll be able to say, oh, I am sure that the person in front of me after assessment is 4 or vulnerable. Next slide. In the social domain, similar things, so thriving and doing well as a stage 1 to 2, and very severe, unable to participate in any social exchange, even when visited. I think one of the challenges we have during the COVID pandemic guidance is we may think people are in the severe range because they're housebound and isolated, but it isn't because of them, it's because of other factors. Next slide. Functional domains, similarly thriving and well at stage 1 and 2 to very severe, being dependent for all aspects of daily living. So again, after assessment, you can fairly confidently place people at a particular stage. Next slide. And finally, and most importantly, the cognitive domain, because cognition is something that you can't really see immediately on visual inspection. So you need to have probing questions about how the person's cognition is functioning, so that you need to dig deep enough. And this is one of the hidden factors in frailty assessment, that if you don't ask for cognition, you won't know where to place them on this level. And it may be the most important driver of a person's global frailty. Next slide, please. So here's a screen full of famous, well-known people. And all of them, in their later years, developed dementia. And all of them, in their later years, if they were seen by one of us in the specialized geriatric services in their late 70s, early 80s, we would actually call them frail because of their cognitive impairment. But from their images, they look vibrant, they look healthy. You would not be able to tell. Next slide, please. Being frail, like I said, increases the risk of having bad things happen to you. And once they get those complications or adverse events, they can become more frail. So they can move from a frailty scale score of 4 to 5 to 6. And the thing that we want to avoid is to have that change permanent in terms of worsening. So I would say in global terms, between frailty levels 3 to 6 or 7, if you really want to be very optimistic, there's that dynamic fluid state, and you can go up and downwards as long as you've got specific interventions that will help the individual. Next slide. So what about frailty and surgery? Every year in Canada, more than 200,000 older people go for surgery, and this number is ever increasing. And of those 200,000, 40%, so almost close to 100,000 people by now, are people living with frailty. Like I said, frailty is a construct, it's a state. So you might say that 100,000 people going for surgery are not happy. So that might be an equivalent. So what can we do about that? Because I had mentioned that if you are frail, you are at higher risk for adverse events and bad things. And looking at exercise pre-op or prehabilitation, there have been small studies that show that this may be a promising intervention, although the trials have been small with small numbers of 54, and single-sided trials have been reported in the past. Next slide, please. So again, people living with frailty, if they go for surgery, that frailty state will predict that they have increased chance of dying, increased chance of being admitted to the intensive care. They've got longer length of stay in hospital. They have a discharge not to home and to institution. They've got a decrease in their level of independence, and they've got an increased patient report of their disability level following the operation. So are we really doing those individuals a favor by submitting them to surgery? Now, surgery, yes, there are risks and benefits. The benefit will be, okay, your bowel cancer is removed, your problem has been excised or fixed or whatever. But if you've got a level of frailty and you've collected complications from that surgery, you may not have reaped the benefits of that surgical intervention. Next slide. So is frailty an important pre-op risk factor? So there's these 4 points. Is it common and prevalent? And the answer, of course, is yes. So I've shown previous figures saying 40% of operative patients in the older age group have frailty. Is it strongly associated with outcomes? Again, the answer is yes. They're more likely to die, twice as likely to die if they are frail. They have twice as likely to have complications, like I said, loss of independence, discharge to a place not home, and increased disability. Does it add new information if you figure out somebody's frailty state? And the answer is, again, yes. And I'll show on the next slide why that is. And the most important question is frailty modifiable? And the answer to that is probably yes. So exercise, nutrition, and definitely geriatric co-management has been shown to manage frailty and at least not make them worse than when they came in, and sometimes even better. Next slide, please. So this was a study published about 4 years ago, and when you add frailty to the usual risk factors for death, predicting for death after surgery, so you see the normal ones are age, sex, the American Society of Anesthesiology risk scale, and the actual procedure, so what kind of surgery they had. If you add frailty to that mixture, then you have a 1 to 7% increase in discrimination, so you can figure out who's more likely to have a disability or to die, and a 2 to 8% increase in discrimination in terms of who's going to end up in a nursing home. So it does add important information. Next slide. So here you see a comparison on the left of just those simple previous risk factors, so age, sex, ASA, and procedure, and then on the right, adding a frailty measure. So the frailty assessment to the patient assessment so that you can get a better idea of what's going to happen to them post-op. So the ideal would be as close to that dotted line that what's actually predicted is observed. So you see on the left, the curve falls off, whereas if you add frailty to the mixture, the curve almost meets that perfect line so that what you think is going to happen is actually what you see. Next slide. So what can we do about people living with frailty going for non-cardiac surgery? Next slide. We want to prepare these patients. So prepare stands for preoperative exercise to decrease postoperative complication rates and disability scores. So this is a double-blind, or not double-blind, it's a randomized trial with multiple partners across multiple sites. So you see some of those sites. So Ottawa, Alberta, Kingston, Toronto, Calgary, McGill, across the country, multiple sites. Next slide. The trial will test the effectiveness of a home-based preoperative exercise program, so prehabilitation, before they go for their surgery. And the idea is to decrease the patient-reported disability and the postoperative complications in older people who are identified to be frail by assessment methods and going for major surgery. Next slide. So it's a parallel arm, multi-center, randomized controlled trial, 11 Canadian hospitals. People have to be older than 60. Their clinical frailty scale is 4 and above. They're having scheduled major non-cardiac surgery. So there's a listing: vascular surgery, intrathoracic, intra-abdominal, pelvic, ear, nose, throat. And they're expected to be in hospital for more than 2 days. And you see the collection of hospitals across Canada that are participating in the study. Next slide. I've mentioned inclusion. So people over the age of 60 years old who are living with frailty, and their surgery date is scheduled for more than 3 weeks from the time of enrollment in the study. Exclusion: if they don't speak English or French, they're unreachable by telephone. They're really having surgery for palliative purposes, and excluded the cardiac surgery, neurologic or orthopedic procedures, because if you have an operation on your joint or spine or your nerves, then your functional level may change significantly regardless of other factors. Next slide. Here's what the intervention looks like. It's home-based exercise. 1 hour sessions, 3 times a week for 3 weeks. Like I said, the inclusion is the surgery has to be more than 3 weeks or more after enrollment, so at least you have the time to do the exercise program. So that's like 9 episodes of, or 9 sessions of exercise at home. They include strength training, aerobic exercise, and flexibility. So what do we get these people to do? In strength training, they do push-ups, seated row, chest fly, deltoid lift, biceps curls, triceps extensions, sit to stand, hamstring curls, standing calf raises, modified chair-seated abdominal crunches. Oh, that sounds absolutely horrifying and terrifying. Well, I'll show you what these really look like. They also need to walk for 20 minutes at moderate intensity and increase by 10% their daily step count per week. And flexibility, they got all sorts of stretches. Wow, this is sounding like a really intensive exercise program. And it is. Next slide, please. So in the upper section, you see how all these various exercises are accomplished using your ever-loving TheraBands, or those resistant bands. And most of these activities are done in and around a chair. So easy to do in the home situation. You've got a whole bunch of stretching exercises involved. And again, you do, it's like a gym rotation. You go through all those various things and various repetitions, and then you've got 20 minutes of walking involved in all that. The first session, of course, is done with a rehab specialist. So all these exercises are done with the person, and probably even the second and even the third, and then afterwards, it's phone call reminder saying, are you doing your exercises 1 hour, 3 times a week? And how is it going? Do I need to give you a refresher, etc.? Next slide. What did the people in the control group get? They got a pamphlet. So World Health Organization recommendations for physical activity for people older than 65 years old. And they got a pedometer to measure how much walking they did in the 3 weeks leading up to their future operation. Next slide. So what was the study going to look at as the patient outcomes? So patient reported disability 30 days after surgery. So using the World Health Organization Disability Assessment Schedule. There's post-operative morbidity survey. There's all sorts of process and patient outcomes. So look at what actually happened to these patients following their surgery and follow up to 1 year afterwards. The aim was to recruit 750 participants across the whole study and those 11 hospital centers. Next slide. Just to show you how comprehensive the measurement will be, this is like all the measures that each one of those participants is going to have. So lots of physical measures, adverse events measures, function, quality of life, etc. So all the way out to basically a year post-op. Next slide, please. So what I've described so far is what frailty is, the fact that many people going for surgery are living with frailty, and a trial that is going to happen to perhaps look at whether intervening with a home exercise program will change that dynamic of frailty and surgery. There has already been a feasibility trial done in the surgical oncology program at the Ottawa Hospital, just to make sure this whole thing works. And the completion of the feasibility trial was delayed because we had to put on hold all clinical trials because of the COVID pandemic. So hopefully this will be finished early next year. And once the feasibility trial is finished, we get the process all figured out and we can kick off the real PREPARE trial sometime, hopefully by mid-2021. and it will last for 3.5 years because that's how long it'll take to accrue all those patients across all those multiple sites. And currently, Dr. Dan McIsaac, who is the principal investigator and an academic anesthesiologist, his team had created an e-learning module. Because of all the sites, we needed research assistants that were very comfortable in assessing for frailty. So this e-learning module was scripted, developed, recorded, and tested so that people learn how to do this in a very standardized fashion and to score the frailty for all those patients. And in fact, if anyone in the audience is curious about seeing this, it is available. I can send you the link, and you can learn how to do frailty assessments, and there's a knowledge test at the end, and if you do well, you'll get a little electronic certificate saying you are now able to do frailty assessments. Next slide, please. So how did people react when they enrolled into the study and they had to do this really intensive 3-week, 9-session exercise routine? Well, this is the feedback from interview. I think it's about 20 patients were interviewed that had gone through the study. Some of the barriers they felt is they had already had impaired mobility, so that would interfere with their completion of the exercise class or their sessions. Fatigue and baseline fitness, so if they were not fit before, they had difficulty completing it. Not sure why weather comes in there. Maybe they wanted to do many of these exercises on the back porch or something. Barrier, guilt when unable to exercise, don't we all? And time. Again, these are 1-hour sessions 3 times a week for 3 weeks. So maybe all these older people had busy lives. The facilitators program was easy to follow. The participants had really good support from their family and friends and the research team, especially the research assistant and the kinesiologist who designed the program and coached them through it and called them frequently and said, let's get going and how are you doing? The participants had a sense of self-control and self-perceived health benefits by doing the program. They felt that it was well suited to their needs, and they felt that the program goals were attainable and they enjoyed it. Global feedback was that they felt that sometimes they would have appreciated a more individualized exercise program and more variety in the equipment. I guess some of those people were more fit than others. And globally, the feedback from the participants that the lack of experience with exercise was not a barrier. So if you have somebody who's been rather sedentary and you throw this 9-session exercise program at them, they were still able to participate to the degree that they could. Next slide. So in summary, surgery can be considered an episode of controlled stress. You have it scheduled, you know it's coming. So if you're an older person and you're living with frailty, depending on the degree of that frailty, you may not reap all the benefits that the surgeon has told you that will come out of that surgical procedure because you'll have complications. You may develop delirium, you may have an infection, you may have a wound dehiscence, and all these bad things. And in the end, you might not go home, you might end up in a nursing home. So is that really what you want? So if these older people who have been identified who are frail and have to go for surgery or choose to go to surgery, what can we do? It sounds that an inexpensive prehabilitation exercise program can modify their postoperative trajectory. And the hopes, once we get the whole study launched and accrue and finally get the full trial finished in about 4 years' time with all the data and analyzed, I can certainly come back and tell you what worked what worked really well, what didn't work so well, and again, to allow many more of our older people who have to go to surgery reap those benefits. Next slide. And I'd be happy to answer questions at this point. Thank you.
Thank you very much, Dr. Huang. Great presentation and great way to connect it with some of the work that you've been doing with older adults and who have cardiac, non-cardiac surgery needs. So are there any questions? I'm just looking at the question board and I don't see anything published at this point in time. And so maybe people just need a moment to you kind of walk into that live event Q&A section. So it is probably up as Stephanie had alluded to in the opening slide. It's over up on your top right-hand corner, or at least on our screen, it is. And so if you have any questions, please ask them. Alan, I'm just wondering, like from the experience to date with this initiative, are there things that you're thinking about that could be put in place proactively within primary care to kind of maybe identify opportunities for you know, kind of health promotion, health prevention, you know, with potential cardiac patients who could avoid surgery?
I think the most important aspect going forward is since the proportion of people, older people, is increasing, it is the future detection of frailty for everybody. And this is I think a project that will take the next 10 years to complete, doing frailty assessments in the preoperative clinics, doing frailty assessments in the emergency room, doing frailty assessments in primary care, in the home, anywhere. And as long as everyone has the skill to do the frailty assessment in a standardized fashion and land on a proper level of frailty, not based on just a glance and a look-see, but really look at function and especially cognitive function. By identifying frailty, then we can start to target better and try and keep them at that level or even improve their frailty level with targeted interventions such as exercise and nutrition.
Super. And there has been a fair bit of work within primary care of looking at the introduction of the clinical frailty scale and kind of the in building that tool into the EMR and creating a baseline, but then also using it as maybe an opportunity to be more you know, identifying those patients who might have a score of 3, 4, 5, 6s that could benefit from specialty services sooner than later for that initial comprehensive geriatric assessment. And are there opportunities that you see that maybe to kind of make it more meaningful in terms of introducing that score or tool within primary care? Because sometimes it's a struggle of there's so many competing factors that primary care has to build that tool into their warehouse of other things that they have to do, that it makes it a challenge sometimes.
I think practically speaking, moving forward, it may not be a thing that they would do every year on every one of their patients, but I think the training is the first step, that these primary care people know how to do the frailty assessment in a standardized fashion, so they just don't quickly look at an individual and say, yeah, she's frail because she looks tiny and she may have broken something. She may not be frail based on her physical appearance and her function, whereas the burly 200-pound guy that presents very, very well, in fact, may be frail because of cognitive impairment. So again, to get away from the snapshot look and to scratch beneath the surface for function and cognition on an as needed basis. And if you suspect something's not quite right, to be able to get that assessment done quickly and then focusing in on the services required.
Okay, super. Thank you very much. I don't see any other questions in the live event Q&A, so maybe I'll just give another thanks and appreciation, Alan, for presenting this morning on better preparing older people living with frailty going for non-cardiac surgery. This presentation was recorded, so it will be posted on our website under the regional rounds that can be located on our at our website of www.rgpeo.com. And in saying that, our next regional rounds is on Monday, October 26th, with Helene O'Connor and Dr. Genevieve Lemay on diagnosing dementia, going beyond the MOCA. And it's probably good timing because if you know the MOCA certification is coming out, and I think they've pushed it back to December 1st as a deadline for that certification. So please go to the RGPEO.com to complete the evaluations, as we find the feedback is quite helpful in preparing for future events. And if you require any credits for nursing certification, please contact the RGPEO at toh.ca through our website to get that CME credit. So once again, thank you.